Fifth metatarsal fracture. I broke my foot. What do I do? I'm Dr. Paul Zalzo.
I'm Dr. Brad Weenie. Welcome to Talking with Docs. We have a guest, Dr. Danny Aurora, foot and ankle surgeon, is going to tell us all about this fracture.
Thanks for having me, guys.
Well, thanks for being here.
Okay, so let's start at the beginning. What is your fifth metatarsal?
So it's a bone that's lining up with the baby toe on the outside of the foot. It can commonly be fractured. It's a very unique bone in the sense that the blood supply could be compromised that area. It's not the greatest bone in terms of blood supply that keeps it alive, and that's why a lot of times fractures can happen in that area. There's a big tendon that attaches to it called the peroneus brevis. There's also part of the fascia, which is the thick band on the bottom of the foot that attaches to it. So when people roll their foot in a high energy type fashion, the bone can sometimes pull and crack in the area where it's a bit weakened.
Okay, so you stepped off a curb, you missed a step, you're wearing funky shoes, tripped on a kid's toy, whatever, you twisted your foot, and you can break your fifth metatarsal, which is the bone on the outside of your foot. Do you need surgery for that?
Yeah, so I think the first thing is to identify the injury.
Okay.
Getting an x-ray will determine whether or not there's a fracture. Another important thing is to determine where the fracture happens. There's different grades or locations of where that fracture can happen.
In the garage, in your bedroom?
Yeah, that for sure. So definitely where where it's happening in that sense, but I think more on the bone in terms of the x-ray, and that could determine also the treatment for it.
So the location of the fracture, the anatomical location of the fracture.
Correct. Not the location of where you injured it.
Okay, and people are going to talk. Let's go back just a tiny little bit. So you're going to have pain, you're going to have swelling, you might have difficulty weight bearing. So this is going to encourage you to see a healthcare practitioner. They're going to examine you, they're going to get the x-ray. So now we're looking at the x-ray. And where are the different locations of the types of fractures? So people talk about Jones fracture, and guarantee, leave a comment if you have this fracture, if you have questions, but what's the difference between the types of fractures?
Yeah, so there's different zones, and even then the classification, there's been a lot of studies to determine whether that classification really encompasses all the fractures of the fifth metatarsal, but in a general sense, there's a zone 1 fracture, which is called the pseudo-Jones fracture. That's more at the tip, or sometimes the little tip of that base of the fifth metatarsal gets pulled off, or there's a fracture that goes kind of in that first zone. And then the second zone, which is zone 2, that's in that watershed zone. That's the Jones fracture that's been described. Again, the healing to that bone is not so great because of the vascular supply that's a little bit compromised in that area.
And that's what you mean by watershed. So there's not great blood supply to this area.
So it's kind of like the weakened area of the bone, so to speak. And then there's a zone 3 fracture, which is anything below that or in front of that. That can happen also in the shaft of the bone, which is basically the actual length of it.
And then you need good blood flow to heal a bone. But one of the first hallmarks of healing when a bone breaks is bleeding. And bleeding brings a lot of factors that can help the bone heal. So if you don't have a good blood supply, not you specifically, but if a bone doesn't have a good blood supply by nature, by anatomy, then it can take longer to heal.
And the thought being that those zones can help predict healing. So the zone 1s and the zone 3s or the shafts are better healers, and the zone 2 are the kind of bad actors.
Yeah, and that also could, the zones are important because they'll also add another element to the non-union rate. A non-union rate essentially is the bone actually has a chance of not healing because of that vascular supply that's a little bit more compromised.
Okay.
Okay, now, the vast majority of the time, does this bone heal when it breaks?
For the most part, I would say yes. I would say the majority of these heal in itself. Again, depending on how much displacement, I mean, if the bone is completely ripped off, depending on the zone and the location of the fracture, that could add an element to it being either a delayed union or a longer time for it to heal.
And you see a skewed portion of that because you're a foot and ankle specialist, so you get those ones that didn't heal, that people treated for a while, tried to get to heal, didn't heal, and then they send them to someone like you for further treatment.
So you would say the 3 things that predict healing would be the location, the displacement, and then the type of non-operative treatment, I guess, you get, or that even the timing of that treatment. Is that fair to say?
Yeah, and also patient factors, right?
Okay.
Some patients can be more prone to delayed bone healing. Heavy smokers, heavy drinkers, diabetics. Those types of patients will have a harder time to heal because essentially that would constrict their blood supply or potentially prevent the healing in itself.
Okay. Peripheral vascular disease or anything that interferes with your blood supply down
there. Okay, so you got this fracture. You're within the acceptable range of non-operative treatment. What is this going to look like for the average patient?
Yeah, so again, depending on the location of the fracture, like we just mentioned about length of time of healing, I think the big thing is to immobilize it right away. A lot of times patients are put into a short walking boot. If it's in a zone 1 or sometimes even a zone 3, for the most part, you could be weight bearing as tolerated in the boot. The length of time for the immobilization can be anywhere between 4 to 6 weeks in the boot.
Yes.
The healing time, though, for those types of fractures could be anywhere between 8 to 12 weeks. So a lot of times I tell my patients this could take up to 3 months to fully heal on X-ray. So radiographically, it'll take a long time to heal, but clinically, they're going to feel much better in the sense that they'll be able to walk and get out of the boot sooner than that.
Couple quick questions about the boot, and leave your comments about this fracture if you've had it or if you wear a boot. So first, short boot, long boot. There's one that just short boot, so just above the ankle, doesn't have to go all the way up to the knee. Second, am I wearing this while I'm going to sleep? Because patients ask this all the time and it makes them crazy.
So I don't think it's necessary to necessarily wear the boot at for sleeping. I think at the beginning when it's very swollen and painful, there could be a role for that immobilization.
For comfort
and
even.
for comfort, because rolling on it could be sensitive or tender on the outside of the foot. The other thing too is I always tell my patients to untuck the sheets to make sure that they're not getting the tension of the sheets in, which will cause more pressure on the foot.
All right, so boot for sleep, maybe in the beginning, but generally for the majority of the time, you're not going to be wearing the boot in bed.
And then the other thing I was just going to say, if it's a zone 2 fracture or if there's a lot of displacement, or if the bone is really off or more turned away or in a worsened position, sometimes we'll cast them for about 2 to 4 weeks to just get the bone to heal. So we don't want it to move out to give an increasing chance of a non-union, which in the zone 2 could be up to 30%.
Are you preferring the cast because you're going to mold it a little bit to try to push it back into place, or just because you don't want people taking it off?
So it's a little bit of both. So the molding of it in itself will keep the foot in a good position, but also just for compliance, so there's no chance of people taking it off or walking on it because they said, oh, I just had to go to the bathroom, I put weight on it. So.
Right.
All right, so you've got your phase 1 here of this injury is that period of immobilization, which can be 4 to 6 weeks. I usually go straight 6 weeks personally when I treat these. And then after that, let's say things look like they're progressing. There's less pain, less tenderness. The x-ray looks like there's some callus there. It's starting to heal. Is there a role for physiotherapy or physical therapy with these injuries?
Yeah, so I think at the beginning you could do some early range of motion, get the swelling if there is swelling at that point, but definitely early range of motion and getting the muscles to start activating again. If you're immobilizing a foot or an ankle for like 6 weeks, that's a long time for the muscles not to be starting, to wake up and move. So you really want to get those going essentially because you don't want to have a weakened ankle, which you could roll your ankle again, have another injury or re-injure it as well.
When you say early, we're not talking early like an ankle sprain early. We're saying let's get the bone to heal, so 4 to 6 weeks, and then we're doing physiotherapy?
So around 4 weeks or so, it's safe to get out of the boot to do some gentle range of motion. You're not doing some heavy strengthening. Mm-hmm. The swelling has gone down. The bone's starting to get sticky where it's starting to heal. And again, you're being followed by whether it be a doctor or orthopedic surgeon, where they're getting serial x-rays to make sure that there's healing. And that could determine how quick or how more aggressive we could push the rehabilitation.
When you're getting rid of the boot, I'm assuming you're just going to wean it a little bit. Being weaning, I like
no
weaning.
pun intended.
No pun intended. But you're using it a little bit less, and then transitioning to, I tell people like a firm soled shoe or something that goes up a little higher to provide some side-to-side support. Do you talk to people about that, or don't bother, whatever they want?
I think just a well-supported shoe, definitely no heels, that kind of thing, where you're going to be prone to rolling it. But it's in a gradual fashion. So always start at a home controlled environment, take the boot off, feel comfortable, and then you can transition to remove the boot when you're outside the house.
Okay. So you get people to wear red Chuck Taylor high tops, Brad? Is that what you do?
I do like Chuck Taylor, sure. It's a good shoe.
Lace them up tight.
Okay, so say you're one of the people that have gone on to not heal, and it's still displaced, it's still sore, you're still having trouble, and now you've been referred to you. How do you decide whether or not someone should get surgery or not?
Well, so exactly what you said. So constant symptoms, there's sign of on x-ray that the bone is not healing.
Yep.
There's a role for surgery. And I think there's even a push to doing surgery in specific populations. So high-level athletes and the type of fracture, whether it be a Jones type fracture or even a zone 3 type fracture, the fifth metatarsal, surgery has been shown to allow athletes to get back quicker to their sport and essentially to increase the union rate to really make sure that the bone heals.
And this is with screws and or a plate, I'm assuming.
Yeah, so depending on what type of fracture pattern, then that's how you'll determine how you'll fix it. And usually if it is like fixable with a screw, you'll put a solid screw that goes right through the bone, it holds it in position, and that increases the chance of union and really stabilizes the bone.
Right.
Okay, and that screw stays in forever, or do you have to take it out down the road?
So a lot of times we bury it on purpose so that it doesn't affect the joint where the fifth metatarsal articulates in the midfoot, but usually it stays in and we don't take it out.
And then similar to the ankle sprain, lots of physiotherapy to get back to strength, range of motion, and stability before you consider return to sport or return to work.
Yeah, absolutely.
Okay?
There's
Now
your
you know.
fifth metatarsal fracture. I'm glad we asked.
Yeah, absolutely. Please leave a comment. Let us know your experience with the fifth metatarsal fracture. If you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
Thanks, Dr. Aurora, for joining us for the fifth metatarsal.
Thanks for having me, guys.
See you next time.